I'm very pleased to be here at the American Neurologic Association meeting and to talk with Tracy Dixon-Salazar. You gave a terrific talk, and I wanted people to understand what it was all about because you've done some basic genetic research and it led to improved treatment of your own daughter. So can you tell us how you got involved in all of this?
Well, it started out about 17 years ago when my daughter developed a very severe form of epilepsy. And at the time I was a stay-at-home mom, but no one could tell us why she went from being a healthy 2-year-old to being a child with severe, intractable, progressive epilepsy. And it just sort of ate away at me. And so eventually I started going to college and fell in love with science. And then after 15 long years, got a PhD in neuroscience. And it wasn't that quick, instantaneous. It was a long, arduous process, but I did fall in love with science, neuroscience, and neurogenetics in the process. But it never stopped eating away at me, this why does my child have epilepsy? And so I thought, I want to get into neuroscience and research because I want to help the next generation of children like my daughter out there. I never thought I'd do anything to help Savannah. I know that probably sounds weird, but I really didn't. I mean, I have a child. She was having hundreds of seizures a day at her worst, and at her best, she was having 10 seizures a day. She had failed 26 treatments. She suffered, cognitive decline. And so I really kind of thought, okay, the damage is done. But that didn't turn out to be the whole story. The rest of the story was that as I was working in a research lab doing my postdoc, exome sequencing really came to the forefront. And this is a technology where you can sequence the part of the genome that codes for proteins, so the exons, the exome. And the researcher who I was working with, Dr. Joseph Gleason at UC San Diego, said, we should really enroll your daughter Savannah in this study, and we should sequence her exome, because at that point she was having about 300 seizures a month, and more severely she was going into something called non-convulsive status epilepticus at least once a week, if not 3-4 times a week. And so she was very severe, and it was getting worse. And so we sequenced her exome, and part of my job as a postdoc at that time was to analyze the exomes, really. I mean, we brought this technology to the lab, me and a technician that worked there, and we were responsible for the analysis and the pipeline and all of that. And so we analyzed Savannah's exome. And initially, we were looking for the cause of her epilepsy, which most of us, in research do. I mean, that seems to be the direction to go. But quickly we transitioned to this idea of finding something that might work as a treatment for her. And we did this because we had some other success stories in the lab where finding the gene had changed treatment in those patients. And so in Savannah, we started searching her genetic variation for something that would be treatable, because again, she's very severe and it was getting worse. And we found something. We found 25 mutations in genes that regulate calcium signaling, 14 of which were in calcium channel genes themselves, 6 of which were in L-type calcium channel genes specifically. And when we went back and made a case for why a drug that targeted these channels would work, we actually had a rather strong case to suggest that Verapamil, an L-type calcium channel blocker that's FDA approved for arrhythmia and hypertension and some other heart disorders, might work for her.
So let me interrupt you for a second to ask about that, because here you are working in a laboratory and you've come up with a theory that this might work. It also could make her worse. And you weren't her doctor. You're not a physician, you're a PhD.
Yes.
So you must have had to have a discussion with her managing physician and say, gee, I've done this work. Would you be willing to try this? Is that how it played out?
That is how it played out. I began to build a case, looking at the predictions of how the genetic variants would alter the protein function, how many she had, what their relationship was to the normal, the typical population that didn't have epilepsy. And I presented it to the doctor, and I said, I think that we might want to put her on Verapamil. Now, her doctor at the time was Mark Naspeka, a pediatric neurologist at Children's Hospital in San Diego. And I love him because he's an out-of-the-box thinker, but he did scratch his head a little bit.
Well, I would think so. And was he worried that something could go wrong? And were you worried that something could go wrong?
We were. And the way that we justified that was that there had been at least 3 anti-epilepsy drugs that Savannah had tried that had worsened her seizures to the point that the seizure number and frequency increased significantly. And so as her parent, it seemed like trying another drug that might make her worse, what wasn't a step beyond, what we had already done. In addition to that, we really felt like we had exhausted all options at that point. Here's a child who's getting worse, and we are out of choices on what to use to treat her with. The doctor insisted on a full workup of her heart to make sure that it was healthy and wasn't going to respond negatively to an L-type blocker, because L-type channels are not just in the brain, obviously. They're in the heart as well and other organs.
So this is a research study on one person based on what you had found on doing the genome on your daughter. And so was this, you're doing it off-label, Verapamil is not indicated in this. Was she in a research center when she was administered the drug, or did she take the pills and do it at home?
So we were part of the study at the UC San Diego lab that I was working in. So we were enrolled and we were part of the study. And the doctor that I work for, Joe Gleason, is also a pediatric neurologist who is a physician at Children's Hospital where my daughter is seen. And so in partnership, she was placed on this drug. Now she was placed on this drug, as a pill that she went home with, but at any time we could have gone into the hospital. We lived a few minutes away. And you're absolutely right. It could have made her worse, but it was a risk that we were willing to take. There was one other piece of information that sort of it's a correlate, as a researcher and as a science person, but was really strong evidence to indicate that this might work. And that was that every time we put Savannah on calcium supplements over the years, she would always have more seizures. And as a prescribing doctor, you often tell your patients you need to be on calcium supplements because you're on Dilantin, you're on Topamax, you're on these drugs that will leach calcium. So we want you to be on calcium supplements, vitamin D, to keep your bones strong. And so we would do this repeatedly because we didn't know any better, and we put her on them and she'd get worse. And so ultimately, after 3 separate trials, we stopped doing that. And the doctors would say, she needs to be on calcium, and we'd say, no, she doesn't. So
I noticed you were very meticulous in documenting her seizures. When you presented at the meeting, you had graphs of actually showing, so that you were very aware of how many seizures she was having. And so what happened when you gave her the Verapamil?
So I have been very meticulous, and the reason for that is because there was nothing else I could do except count seizures. And what happened was nothing short of amazing. Savannah, for the last 1 year and 10 months on Verapamil, has had a 95% reduction in the number of seizures she was having. So here's a child who was having 300 seizures a month, and that dropped down to about 20 a month, which is still too many. But I think the thing that's really been life-changing for us is that she went from having 3 to 10 episodes of non-convulsive status a month to having 0. And it's been 1 year and 10 months. And she'd never had a honeymoon on any of her treatments longer than 3 months. All of her seizures at this present point are nocturnal, which presents, a much less of a safety hazard, when you're having your seizures, when you're already laying down. So, and, she's really just blossomed. Being out from under all of those seizures. She's come off 2 of her anti-seizure medications and 50% reduction in a 3rd one. And we continue to wean without seeing an effect in seizure number or non-convulsive status appearance. And I feel like we're getting to know her for the first time.
I got to know her just for a second. I saw she was showing me her nails, her pink nails as she came up at the end of your talk. So let's stand back a little bit and talk about this approach to medicine, what I would call personalized medicine, because it's personalized genomics. Each person is different. You didn't find a cure for her disease, but you found modifying genes that you were able to treat. Is that the wave of the future in medicine? And how are we going to do that? It's with 300 million people in the United States alone.
Well, I think that's absolutely possible, and we do that now. In the clinic, you try to look at your patient as the unique individual that they are, and you try to treat them in that sense. But there's also standard of care, and there's protocols that you follow. But here we have a tool for the first time to look at the patient from the perspective of what's unique about them. And I think, yes, this is only a single case, but this is what is possible with our patients. there's risk involved, and so you're going to need to, get past that risk. If the only thing we're ever going to act on in medicine is definite characterized genes that are known to be associated with this genetic disorder or this genetic disorder, or known to be associated with this drug positive effect or that drug positive effect, then we're not going to get as far as if we're willing to take risk. And in patients like my daughter who are so severe, who really are expecting a shortened life expectancy, and the parents are just craving anything to help them, I mean, I think it's a no-brainer. So how do we do this for our patients? I mean, we do it the same way that I did it. You go in and you create hypotheses around what you think might be happening in the child and how you might treat it. It requires really good information on the type of epilepsy and how many seizures they're having, and good phenotype information. And I think a lot of parents are more savvy about generating that information. And it requires a partnership between the parent and the doctor, and between the powers that the administrators and the doctors to be willing to do this. There are certain drug companies or administrations in hospitals that just wouldn't prescribe Verapamil at all, the end, because of the risk. And yet it's such a beautiful story in my daughter where it's had a huge effect in her life.
Well, I agree with you. It is a beautiful story, and it's encouraging for all of us. Thank you.